Thank you for joining Cancer Support Community Atlanta for Frankly Speaking About Chronic Blood Cancer, facilitated by Dr. Carlos Franco with Georgia Cancer Specialists. Please visit our website, cscatlanta.org, for a complete list of live and recorded events. If this is your first time participating, we invite you to complete a new attendee form to stay connected to all future programs.
I just want to clarify that this slide deck is long, is extensive, so I'm not gonna stop with every slide and talk about every slide or the content of every slide. I'm just gonna concentrate on the science of the conditions that we're talking about today, CLL and CML. The slide set or the slide deck will be available to you after the talk today, so you can review any other recommendations with regards to communication with your healthcare team, with the questions that you want to ask your healthcare team, your interactions with your family members at home when you have these conditions. So all of that will be available to you so you can review it afterwards. I'm going to try to concentrate on what you want to hear, which is what CLL and what CML, how we evaluate and how we diagnose CLL and CML, and what are the treatment options. I have to say that there are several other conditions that have become chronic with regards to the malignant hematology diseases or conditions. We don't just have CLL and CML as chronic blood cancers. There are others like myelodysplasia, multiple myeloma, myelofibrosis, chronic myeloproliferative disorders. These are all chronic malignant conditions of the blood. So we're just going to concentrate today on two, perhaps the most common, actually the most common, CLL, and another one that is not as common as CLL, but one that we can essentially, quote, cure, unquote, which is CML. So we'll be talking about those two today. And we'll be happy. And the other reason I'm trying to concentrate on the science and avoid the other slides in the set is because I want to be able to answer your questions at the end. Now we are talking about, okay, Emily already introduced me. And let's see, this program was developed by the Cancer Support Community. Northside Hospital is basically responsible for this presentation. I have been a doctor at Northside for 32 years, and I couldn't be prouder. It's a great organization, a great cancer institute, designated by the NCI. I have no financial relationships or affiliations with any of the companies that make the products that I'm going to be talking about. Okay, the workshop overview, introductions. What is CLL and the other condition that basically is the same as CLL? CLL is chronic lymphocytic leukemia. SLL is small lymphocytic lymphoma. They are essentially the same, and I will explain that later. CML is chronic myelogenous or chronic myeloid leukemia. We're going to be talking about symptoms and diagnosis, communicating with your healthcare team. Again, that will be a subject of your review later because I'm not going to go over those slides in detail. So I'm going to concentrate on symptoms and diagnosis, treatment options, perhaps a word about clinical trials, because clinical trials right now are not as important because these conditions can be managed by anyone, anywhere, any hematologist in the community, in the countryside, on the coast, in academic centers. All these drugs that we have for CLL and CML are available everywhere. So we can provide in the community the same quality of medical care that you can get in the academic settings. In fact, we manage many more patients than academic settings in Georgia because we are available everywhere. So we can manage with the best available options or best available treatment anywhere in the States. So then living with CLL, SLL, and CML, we'll touch on that later. Now, let's see. I believe, oh, I'm going the other way, I guess. Hold on, next. Okay, what is CLL and SLL? We're going to be talking about key terms, prevalence, symptoms, and diagnosing CLL. CLL is a cancer. Actually, I don't like to call CLL cancer because it's a condition that most patients have for 10, 15, 20 years. So I avoid the word cancer. CLL is a malignant condition. Yes, it is malignant because the lymphocytes are malignant. And that means that they basically divide and they expand uncontrollably. So they keep growing. They do not obey any regulatory mechanisms because they are malignant. So they grow and they divide without control. That's why they are considered malignant. It's a neoplasia, but I don't call it cancer because again, many patients survive with it for many years without need for treatment. Now, lymphocytes are a type of white blood cells. There are many types of white cells: granulocytes, neutrophils, eosinophils, monocytes. Lymphocytes happen to be a type of white cell, but it's specifically a type of white cell that is part of the immune system. Why? Because lymphocytes become plasma cells and they produce immunoglobulins, which are proteins that fight infection. On the other hand, the lymphocytes themselves are able to fight bacterial infections and are also able to fight cancer cells. So they can fight with the immunoglobulins, they fight bacteria and also toxins, and some types of lymphocytes, actually CD8 lymphocytes, CD4 lymphocytes, can fight viruses also. Now, there are other types of leukemias that are acute, and we are not going to be talking about today. There is acute lymphoblastic or lymphocytic leukemia. That's an acute leukemia. We're not going to talk about that. We are going to talk about chronic myeloid leukemia, but we're not going to talk about the acute counterpart, which is acute myeloid leukemia. So only chronic leukemias. Now, small lymphocytic lymphoma is a cancer that affects lymphocytes. Again, I don't like to call it cancer because patients with small lymphocytic lymphoma could survive 10, 15 years. So I don't call it cancer. And the only reason why we're talking about small lymphocytic lymphoma today is because it is the same disease as CLL. Chronic lymphocytic leukemia, CLL, is the same disease as SLL. The difference is that in chronic lymphocytic leukemia, the abnormal or malignant lymphocytes are found in the blood and in the bone marrow, okay? In small lymphocytic lymphoma, the malignant lymphocytes are found mostly in the lymph nodes, okay? Now, there could be some overlap. You know, you could have CLL cell in lymph nodes and you could have SLL cells in bone marrow, but as a general rule, CLL is called when most of the cells are in the blood and in the bone marrow. SLL is called when most of the lymphocytes are in the lymph nodes. CLL may be a slow developing ongoing condition. Some people with CLL do not need any treatment right away and may never need medical treatment. Let's say that an 85-year-old man is referred to me because he has 20,000 lymphocytes in the blood, has 30,000 white blood cell count, 20,000 lymphocytes or 25,000 lymphocytes. I do the flow cytometry, which is the test that we use to confirm the malignant nature of these cells, and they prove the flow cytometry proves that the patient has malignant lymphocytes. Fine. So CLL, he's 85 years old. He feels fine. He doesn't have any weight loss, any night sweats, any enlarged lymph nodes in the exam. He doesn't feel bad. He doesn't have any infections. And he's making immunoglobulins to fight infection despite the CLL. So what do I tell him? Well, he may never need treatment. He definitely doesn't need treatment right now, but he may never need treatment. He may die with this condition, not from this condition. And I tell the patients that. 85 years old with 20,000 lymphocytes, he may never need treatment. He may never experience progression of CLL, and he may die with the condition, not from the condition. He may die from heart disease, from a car accident, from kidney disease, diabetes, whatever, but he may never develop progression of the CLL. And many patients fall under that category. Even 70-year-old that survive until 85. I've had many patients that were diagnosed at 70, 75 who never developed treatment or significant progression. So in many patients, this condition could be a chronic condition like diabetes that they have, or other conditions that may never need treatment. Diabetes needs treatment anyway. So other people have a form of CLL that grows more quickly, okay? Some people may need to start treatment right away when they are diagnosed with the disease. Let's say that patients are having 20-pound weight loss, they have a fever, they have pneumonia, they have big lumps in the neck and in the armpits, they have a big spleen. So patients that present like that will need treatment right away or very soon. Most people eventually need to be treated and will be treated on and off for years. I've had many patients in their 50s and 60s that I treated, let's say when they were 55 or 65, they went into remission. Then when they were 60 or 70, I had to treat them again. And I put him back in remission. Then 5 years later, I had to treat him again. I put him back in remission. So that could happen. Treatment on and off for several years. Now, there is currently no cure for CLL. I cannot tell patients that they can be cured from CLL, but it is possible to live a very healthy and lengthy life with the disease and continue to do many of the activities of your daily life. In fact, most patients that I have with CLL have a normal or have a good quality of life, and they do everything they want to do. Now, what are things that you may hear if you have CLL when you come to the doctor's office? You may hear that the CLL is chronic. Chronic disease is anything that grows beyond 6 months to a year. So if you have a condition beyond 6 months to a year, that's called chronic. If you have it this week, that's acute. If you have it for more than a month or two, that's subacute. But more than 6 months to a year, that's called chronic. Now, anemias. Many patients with CLL could develop an anemia on the basis of the overwhelming population of lymphocytes in the bone marrow. If the patient have 50, 60, 80% lymphocytes in the bone marrow may not be able to make the normal numbers of red blood cells, and the patients develop an anemia. On the other hand, patients with CLL may develop antibodies. Those lymphocytes may produce antibodies that eat red blood cells or platelets. And the patients develop an anemia from destruction of red blood cells or a low platelet count from destruction of platelets, what we call immune anemia or immune neutropenia. Now, leukemia. I told you, leukemia just means that there are malignant blood cells of some kind, lymphocytes or myelocytes. Lymphocytic, because the malignant cells in chronic lymphoid leukemia are lymphoid cells, lymphocytes. They are not granulocytes or myeloid cells, but lymphocytes. And marrow, the bone marrow is the factory that makes the blood cells. The blood cells are made in the bone marrow. Lymphocytes, white cells, platelets, myeloid cells, red cells, all of those cells are produced in the bone marrow, which is a factory that makes the blood cells. Now, CLL is the most common type of leukemia in adults, making up about a quarter of new cases. So about 25 to even 30% of patients who present with leukemia have CLL. So it's the most common type of leukemia in adults. In the United States this year, there will be about 21,000 new cases of CLL, okay? About 21,000 new cases. Okay, the average age of someone diagnosed with CLL is 71 years of age. That's the average, 70 years of age or so. It is rarely seen in people under the age of 40 or in children. Okay, very rarely. In children, we usually see acute lymphocytic leukemia or acute lymphoblastic, not CLL. Patients under the age of 40, very rarely. I had, in the last 20 years, I've seen only one patient that I diagnosed at age 37, and he survived until about age 55, and that is, he had many treatments over the years and went into remission, but unfortunately, at the end, he developed acute leukemia from the initial treatment that he had, which we don't use anymore. It's called FCR. It's a combination that was developed at MD Anderson, combination of fludarabine, cytoxan, and rituxan. I don't use it anymore because we have much better treatments, and also because FCR causes myelodysplasia or acute leukemia in about 7 or 8% of patients. And I lost 2 patients because of acute leukemia. One patient in her 60s, the other one in her 50s from acute leukemia after FCR. Yeah, FCR was the best treatment in the 90s and in the early 2000s, but not now. We have much better drugs which do not cause myelodysplasia or acute leukemia. Many people who have CLL do not have any symptoms. In fact, most people that I see for the first time with CLL do not have any symptoms, and I don't have to treat them. If a person who has CLL has any symptoms of CLL, they may include fatigue, severe fatigue, weight loss, drenching night sweats, fever with or without infection, because sometimes they have infections because they are immune deficient. They don't produce at normal levels of immunoglobulins, or they may have an anemia or low platelets. Okay, so these symptoms are more likely to be caused by other health problems and do not mean you have CLL. So you can have fatigue because of heart disease or lung disease or thyroid disease or diabetes. You can have weight loss because of something else, tuberculosis, diabetes, depression. You can have drenching night sweats with other things, infections or fever. So you may have an anemia or a low platelet count because of lupus or Sjogren's disease or immune diseases. So many of these symptoms may not be related to CLL, but if you have a CLL patient that presents with these symptoms, then you know that you may have to treat. Since many people who have CLL do not have any symptoms, since many people don't have any symptoms, many times you diagnose and send patients home and you see them every 6 months or a year. A high-level lymphocytes, a type of white cells, without other explanation, is commonly what leads a doctor, usually a primary care doctor, to suspect CLL and to refer the patient to the hematologist, okay? That's the most likely cause of referral to a hematologist. High white blood cell count with a high lymphocyte count. CLL often don't have any symptoms. If there are symptoms, some are the same as other illnesses, and it may require several tests to diagnose CLL, like the test that I talked to you about before called flow cytometry. Okay, so let's go back. So before we go to yes. What are the tests that we do? Basically, we do a flow cytometry. The flow cytometry is a special test, a very sophisticated test or technique that identifies with a ray of light in a tube, identifies abnormal blood cells. We can see an abnormal lymphocyte in a pool of 1 million normal lymphocytes. So it's very sophisticated, very accurate. So we can find these abnormal lymphocytes even in a pool of many normal lymphocytes. So when the flow cytometry finds these abnormal lymphocytes with some antibodies, some markers that are called CD19, CD5, CD20, all those are antibodies that identify CLL cells in the flow cytometry. So that's the most accurate test. And then we do other testing for prognosis. We try to identify with an antibody that is called CD38, for an antigen that is called CD38. High expression of CD38 is poor prognosis. Low expression or no CD38 is good prognosis. Then we also measure immunoglobulin levels. We try to find out if the patient is making abnormal proteins, or what we call monoclonal immunoglobulins, or whether that patient has low levels of immunoglobulins to fight infection, because that's usually the case. Patients with CLL could be immunodeficient or immunosuppressed, even if they are not treated. even if they are not on any treatment, because those lymphocytes are malignant and may not be able to produce normal levels of immunoglobulins to fight infection. Spleen may grow. The spleen may be big, and patients may have discomfort in the abdomen on the left side, in the area of the stomach on the left side. If the spleen grows, many times you feel that there's a pressure, it's a pain or discomfort, or you feel bloated because there is a big spleen in the abdomen. So that also could be the case, and we do an ultrasound of the abdomen to identify or confirm that, okay? Now, what is CML? Now, I have to tell you an anecdote. CML is a disease that is close to my heart because I started practicing with Georgia cancer specialists in Northside in 1990. And at that point, we did not have the TKI, so the targeted treatments that we have now that are excellent, that essentially get rid of the myeloid malignant cell, and the patients survive as if they were cured, as long as they take the medication. But in the early 90s, we didn't have anything other than Hydrea. Hydroxyurea was a medicine that we used to just control the blood count, to decrease the blood counts and make the patient feel better. But the patients usually die within 3.5 or 4 years. So even if the patients felt fine taking hydroxyurea with normal counts, they went into blastic crisis. They developed acute leukemia and died within 3.5 to 4 years. So that was painful to see that. And I can tell you, in memory of these two very dear patients of mine, one very elegant, sophisticated African-American woman, that very elegant and very nice, very kind, hardworking woman in her 50s. And I sent her for a bone marrow transplant from her brother. Now we have the best transplant center at Northside. I don't have to send anyone anywhere, but I used to send them to Seattle, the Fred Hutchinson Cancer Center that used to be the best transplant centers in the transplant center in the 90s. And she died of complications of transplant. And then another one, a patient in his 30s, newly married. This guy, newly married, very nice. He was the manager of a cafe here at Perimeter Mall, across the street from Perimeter Mall. And newly married, sent him to Seattle. He also died from complications of allogeneic bone marrow transplant. So I always remember these patients. I also remember a very dear patient of mine who I have seen, has been my patient for more than 30 years now. I saw it in 1990. She did fine with the transplant in Seattle. She did fine. She's still alive. She's with me. I see her every 6 months. But I have to give her IV IgG. I have to give her immunoglobulins every month, all her life, because as a consequence of the transplant, she developed what we call chronic graft-versus-host disease. And she had a severe lung disease that fortunately was cured, severe lung infection that was cured, but then developed this immune deficiency. She's unable to produce normal numbers of immunoglobulins to fight infections. So I have to give it to her every month for 30 years. So anyway, she comes to me every month for infusion, but I see her every 6 months. She's alive, she's fine, but again, I have to give her immunoglobulins to fight infection every month in the vein, an infusion for 4-6 hours. So transplant was the only answer in the 90s. But again, we lost about 25 to 30% of patients during allogeneic transplants. And then interferon. Dr. Kantarjan, one of my heroes, who basically discovered and developed imatinib or Gleevec, the first drug for CML, with Dr. Drucker in Portland, Oregon. Those two developed this, and but before the imatinib, he used to treat patients with interferon. Interferon 3 times a week had a lot of side effects. People sometimes went into remission with CML, chronic myeloid leukemia. Sometimes they survived a little bit longer than with Hydrea, but they had a lot of side effects. So when the interferon, the once a week interferon, the pegylated interferon was developed, it was a blessing, because at that point, we didn't have to give 3 injections of interferon weekly, which made the patients feel like they had the flu all the time. They were all the time feeling as if they were having the flu, achy, feverish with interferon. Some patients didn't, but some patients did. So when when they developed pegylated interferon once a week, the side effects went down, patients tolerated it better, and they had to come for a once a week injection instead of three times a week injections. So that was really a great change. But again, interferon didn't cure CML and only allogeneic transplant. But again, the mortality was high and the morbidity was high from transplant. So when Kantarj and Drucker and other investigators developed the TKIs like imatinib or Gleevec, it was a blessing. My life changed because all of a sudden I had a way to essentially make these patients survive without any major problems and survive for many years without blastic crisis or acute leukemia. So we're going to talking about key CML terms, symptoms of CML, diagnosis CML, and phases of CML. Again, CML is a chronic leukemia, which means that you have it for more than 6 months or a year. Most patients used to survive 3.5 to 4 years. Now they survive beyond 10, 15, and 20 with the new medications. We cannot say that we cure them, but I believe we do. As long as you take the medicine, essentially you are cured because you don't have leukemia. Myeloid, because they are different cells from lymphocytes. These myeloid cells are in the myeloid lineage or myelogenous cells. They are different from lymphocytes. The stem cells that make white cells, they make many different types of white cells. They make granulocytes and neutrophils that are in the myeloid lineage. They make promyelocytes, myelocytes, metamyelocytes. Those are all in the myeloid lineages. And they mature and they become granulocytes or neutrophils. There are other myeloid cells, eosinophils, monocytes, but basophils too. But the cells that we are talking about here is immature or early myeloid cells. We're talking about promyelocytes, metamyelocytes, and myelocytes. Those are the cells that are increased. Sometimes also basophils, but mostly promyelocytes, metamyelocytes, and promyelocytes, metamyelocytes, and myelocytes. Okay, and then leukemia, because it's a uncontrolled proliferation of white cells. That's what leukemia means. Leuk in the Greek or whatever, or I don't know if it is Greek or Latin, but leuk is white. So leukemia is basically uncontrolled proliferation of white cells, and in this case, myelocytes or myeloid cells. CML is a blood cancer. Again, I don't call it cancer. I just call it leukemia, chronic leukemia. Don't like the word cancer there. Starts in the bone marrow, which is the sponge type tissue that produces the blood cells. Okay, now we have bone marrow in all our bones, but we take samples of the bone marrow usually from the hips. Why? Because the hip bones are huge. They have these huge lakes of bone marrow. So it is very simple to take samples of bone marrow from the hip bones. Very simple and very safe and very quick. So, and the bone marrow makes the myeloid cells, make the red cells, the platelets, and the lymphoid cells, all the cells. And also they make some cells like fibroblasts and other cells that basically feed or support the blood cells. CML is caused by a genetic mutation called BCR-ABL. Now, we're going to talk about the Philadelphia chromosome. In the past, before we knew these molecular changes, we called it Philadelphia chromosome because it was found in a lab in Philadelphia. And basically, it was exchange of chromosome material between chromosome 9 and chromosome 22. You know, we have 46 chromosomes, 23 pairs, including the sex chromosomes. Okay, so 44 somatic chromosomes. Now, in the Philadelphia chromosome, which causes chronic myeloid leukemia, there is exchange of chromosome material from chromosome 19 to 22. What do they exchange now at the molecular level? We know that we exchange molecular material called BCR and ABL. They exchange. BCR goes from one to the other, and ABL goes from the other to the one. So basically, there is exchange of BCR-ABL. BCR from one chromosome to the other, 19 to 22, ABL from 22 to 19. So basically, this translocation, that's the name, that's a medical term, translocation the exchange of chromosome material is between 19 and 22, is the BCR and the ABL. So there is exchange, and that is what causes chronic, that exchange, that translocation is what causes chronic myelogenous leukemia. And as I said before, CML is a chronic cancer because it lasts more than 6 months to a year. Now, the exchanges in BCR-ABL, those are the key terms. That's the molecular change. Blast. Why do we say blast? Why do we talk about blast here? Because what kills a patient with CML is blastic transformation. What does that mean? That all of a sudden a patient with CML develops a transformation, an accelerated phase, and later it transforms into acute myelogenous leukemia. And that is what generally kills a patient with CML. But with the new treatment, that doesn't happen. It happens in way less than 10%, perhaps less than 5% of patients that are rarely refractory to the new treatments. And in the past, everyone died with blastic crisis. Now, we hardly ever see it because the patients remain in remission without the expression of the BCR-ABL. So when we treat patients, we measure BCR-ABL. We measure the BCR-ABL at the molecular level, and it has to be undetectable or minimal expression, less than 0.055, whatever, or less than 0.05, but we measure that. Every 3 months, we measure the BCR-ABL in patients taking the TKIs to make sure that it is not expressed or that is minimally expressed, consistent with a complete or major molecular remission. Now, Philadelphia chromosome, I already told you, is the exchange between the 9 and 22. Now, when you present with CML, you may not have any symptoms at all. You may feel fine. In fact, most patients that I see with CML had no symptoms whatsoever. Now, CML can be diagnosed through routine blood test, or if there is another problem. Let's say I've seen many patients that went to the doctor because they had abdominal pain because the spleen was big. And then the doctor does a blood count and he finds 50,000 white blood cells with 35,000 myelocytes, metamyelocytes, promyelocytes, and basophils. So then that patient is referred to the hematologist for the testing, the BCR-ABL testing. PCR is called polymerase chain reaction. PCR is very familiar. I guess everybody is now familiar with PCR because we do PCR for COVID tests. So everybody knows what PCR is. PCR is a laboratory technique. It's polymerase chain reaction, and that is used for viruses, for blood cells. It's basically to find, it's a study of the proteins of the virus and the blood cells. So basically you can find a positive PCR for BCR-ABL, the same way you can find a positive PCR for COVID virus. Okay, so we do that. We can do a FISH, which is fluorescent in situ hybridization. It's also a very sensitive laboratory technique to diagnose CML or blood malignancies. Now, if you have symptoms that may include fatigue, you may be very tired because you have developed an anemia, because you are making too many white blood cells, you may be losing weight, you may have fever, you may be sweating at night, or you may have pain or fullness in the left side of your stomach, in the upper part, because your spleen is big. Most patients with CML have a big spleen. Now, in the physical exam, you're find the big spleen. You're going to find the big spleen. You may find that the patient appears chronically ill or pale, and then you do the blood test. You do the blood count to see that the patient has high white cells, and you look at the smear under the microscope, the blood smear, and you find a lot of early cells, immature cells, myelocytes, promyelocytes, metamyelocytes, basophils, eosinophils. So you find all kinds of immature white cells. Then you do the bone marrow biopsy. Sometimes we do, sometimes we don't, because now we can diagnose with a blood test. So many times I don't do it unless your patient have a profound anemia or profound low platelets, whatever. But many times you can just diagnose with a blood test, the PCR or the FISH in the blood. Molecular testing, I already told you that. PCR or FISH, these tests that we do to find these molecular abnormalities. Okay, most CML patients are diagnosed in the chronic phase, the overwhelming majority. So we have time in the chronic phase without transformation or without progression. We have time to treat with the standard of care, which are the TKIs, tyrosine kinase inhibitors. Tyrosine kinase inhibitors. These are specific drugs that bind to the BCR-ABL, bind to the change, to the chromosomal change at the molecular level. Okay, so if you're in chronic phase, you're likely to survive your normal lifespan. If you are treated early and you respond, you're likely to die the year you were supposed to die from something else. Okay, now if you are in an accelerated phase, you may or may not respond to treatment, because at that point, the number of acute leukemia cells increase, the size of the spleen increases, the blood counts go down, you develop an anemia, low platelets. So basically, what we call accelerated phase is more difficult to treat because some patients don't respond to treatment and they end up evolving or transforming into acute leukemia or blast crisis. But even in accelerated phase, with big spleen or fever or infections or pain in the spleen and anemia, low platelets, even in that phase, we can still treat and put patient in remission. But more patients are likely to develop progression to blast crisis. And blast crisis is bad, is acute leukemia. So basically, the number of blasts go up to the point that the disease looks and acts like acute myeloid leukemia. So in this case, patients do need TKIs. We give TKIs, but in combination with chemotherapy. We have to use chemotherapy because we have to treat like acute myeloid leukemia. And at that point, only about 20-25% of patients will survive. Generally, perhaps 30% at most, or a little bit higher if you go to a bone marrow transplant. If patients with acute leukemia become candidates for transplant, perhaps 35 to 45% will be saved. But other than that, no more than 25 or 30% will survive in blast crisis or acute myeloid leukemia crisis. So you want to diagnose the patient in early phase, chronic phase, or at most in an accelerated phase, so you can treat him and put him in remission. Now, I don't believe I have a slide. Hold on. Yeah, I don't believe I have a slide on TKIs. Let me see. Yeah, no, here is treatment of CLL. In most patients, we treat CLL with observation. We don't do anything. We watch and wait, or watchful waiting. Okay, we tell patients, I have had patients that even with 120,000 white blood cells, 90,000 lymphocytes, feeling fine, good quality of life. You don't have to treat counts. I tell my patients, I don't treat counts, I treat patients. So a patient may have 120,000 white cells and 90,000 lymphocytes. But if the patient feels fine, quality of life is good, no enlarged lymph nodes, no fever, no infections, no weight loss, no night sweats, I just keep watching the patient. I may watch him every 3 months instead of every 6 months, but I don't treat counts, I treat patients. What do I tell him during the, let me see. Okay, what do I tell patients? Okay, if you develop any significant weight loss, more than a pound a week, if you develop any drenching night sweats, if you start having fever or infections, or if you feel lumps in your neck or armpits, or you develop some discomfort in your left tummy where the spleen is, because the spleen is growing, then I need to see you right away, and I may have to start treatment. Again, but it's a combination of things, okay? Again, enlarging lymph nodes, enlarging spleen, fatigue, anemia getting worse, low platelets getting worse, weight loss, fever, night sweat. So those are the reasons for treatment, okay? A combination of such, okay? So the decision to start treatment is made after the interview with a patient that is feeling poorly and after I review the blood counts, and then we decide whether the patient is ready for treatment or not. But that may not happen for years, okay? Now, What are the goals of treatment in CLL? Slowing down the growth and the production of lymphocytes, so to decrease the counts until they become normal. Maintaining your lifestyle. If the symptoms are now affecting the quality of your life, I want to give you your quality of life back. That's why I am going to treat you. Keeping you feeling well enough to carry on your day-to-day activities and feel that you're not sick. And there are new drugs that make you feel like that. Bringing your white blood cell down and improving the anemia if you have developed an anemia, or if the platelets fell or went down, I want to see the platelets going back up, and that happens with treatment, okay? Now, we cannot cure CLL, but we can put you in remission, and you can be in remission without evidence of CLL for years. And if you relapse again and the CLL comes back, I will treat you again, okay? Now, even if there are no signs of leukemia after treatment for a few years, it is likely that the leukemia will come back. It is chronic. It will come back at some point, and we'll have to treat you again. Most people with CLL are treated on and off for years. What are the treatment options? Here in the center, immunotherapy, a drug that is called Rituxan, and another drug that is called Gazyva. Those two drugs are immunotherapy, excellent in combination with other drugs. Sometimes we use them by themselves if the patient is too old and too frail, but otherwise we combine them with others, with what we call chemoimmunotherapy. For example, a drug that is called Trianda or Bendeka. That's a drug, an excellent chemo drug discovered by the East Germans in the 30s. And we didn't know about it until the 80s. But anyway, when after the two Germanies got together, at that point, 89 or 90, we discovered that drug that the East Germans had for 50 years. Anyway, so targeted therapy, Imbruvica, abrutinib, salabrutinib, acalabrutinib. So there are several targeted therapies that bind the B cell receptor. There is a receptor in the B lymphocytes, because as I forgot that 90%, more than 90% of chronic lymphocytic leukemia are B cell leukemias, B as in boy. There are very few T cell or NK cell leukemias, T as in Tony, NK natural killer. Those leukemias are rare. Most, more than 90%, are B cell, B as in boy. And these cells have receptors called the B cell receptors. And the ibrutinib, acalabrutinib, zanabrutinib, they bind to the B cell receptor and render the cell useless and kills the cell. Okay, so new treatments are being tested in clinical trials, such as CAR T cell therapy. A patient who is young and healthy, who develops progression and needs a transplant, many times will get CAR T cell therapy. These are his own immune cells that are grown in the laboratory to fight the CLL, and it's extremely effective. It's a breakthrough, extremely effective for those younger patients that need to be treated aggressively. Otherwise, allogeneic transplant. Okay, so a treatment schedule could be a single treatment. Single. We can give you just ibrutinib by itself, or Gazyva by itself, or Venclexta by itself, or we can combine the drugs. We can give you ibrutinib with Rituxan, or ibrutinib with Gazyva, or we can give you Venclexta with ibrutinib. So there are several ways to treat. Okay, so now just one thing about this slide. We've come a long way, and we are very sophisticated now for diagnosis and prognosis. We test many molecular markers at the molecular level inside the chromosomes of the blood cells to see what mutations are expressed or what abnormal changes are at the molecular level, so we can tell you that you have a good or bad prognosis. For example, expression of CD38 is bad prognosis. Expression of this very ugly molecule called TP53 in your slide, TP53 or 17 deletion, you know, I hate it. And I don't hate anything but TP53 because TP53 is bad. If you express TP53, your prognosis is bad. If you have a 17 deletion, it's bad. So fortunately, only the minority of patients do, but this is bad. So we try to evaluate the lymphocyte at the molecular level to be able to give you prognostic information, and many times we do. Okay, let me see. This is the, hold on, this is a drug that I was talking to you about, bendamustine, Bendeka or Trianda. This is a drug that was developed by the East Germans in the 30s that we didn't know about until the late 80s. Anyway, so, but anyway, FCR, this is a combination that we don't use anymore unless you have what we call a mutated immunoglobulin change. It's very few patients have what we call a mutated IgH, about 10% of patients. So only those patients are treated with the FCR combination. And I told you, because it causes acute leukemia in about 7 or 8% of patients. So we don't use it unless you have that mutated IgH or IVH, okay? And we can tell you that with a molecular test when you are diagnosed with CLL. Okay, I already mentioned these drugs, ibrutinib, acalabrutinib. There is another drug, it is Zidalig or idelalisib, duvelisib, venetoclax. Stem cell transplant is not used for CLL, only allogeneic transplants in young patients. But now we use CAR T cell treatment, which is an immune treatment with your own T cells. Treatment for CLL is targeted therapy. The stem cell transplant is allogeneic from a donor. It's not from your own cells. It's from a donor, allogeneic, from brother or sister. And thanks to the group at Northside, the transplant group, by the way, I don't want to give myself, I don't want to throw myself flowers, but I know that Maxine, my former transplant nurse at Northside, is in the call here. I think she's watching. And Maxine was my transplant nurse from 1997 through 2001, when I was the director of the transplant program, the bone marrow transplant program at Northside. Now, I say that because Maxine was outstanding transplant nurse, and now she's one of the navigators at Northside, the head. Anyway, so she was great. But also I wanted to say this, but because the transplant program at Northside is now the #1 transplant in the country with the lowest mortality in the country for several years in a row. So I say this because it is because of them and their studies that we discovered that we can transplant many patients without a perfect donor. In the past, we used to do it just with perfect donors, brother or sister from the same parents, perfect donor. Now we can do half donors, half match, half what we call haploidentical, thanks to the studies that they did at the transplant team at Northside. Dr. Holland, Dr. Morris, Dr. Sol, Dr. Solomon, Dr. Bashi, all these doctors, excellent doctors that have done many studies showing that you can transplant with the half match. It doesn't have to be a perfect match anymore. So you can have a transplant from your son or your daughter or your father or your mother. It's amazing what they've done. And now they are doing many haploidentical transplants with the lowest mortality in the country. It's not advertising, it's the truth. It's really amazing what they've done. And it's great news for you, because if you ever need an allogeneic transplant, you can have it at Northside with a half match. It doesn't have to be a perfect match. Now, I hope you never get to the need for a transplant for CML, because we have targeted therapies that have a 90% response rates. 90% of patients that take TKIs or targeted therapy in CML go into complete remission and remain in remission for many years, at least 10. So this is what I wanted to talk about, these drugs. Imatinib, Gleevec was the first one. The studies came from MD Anderson. My friend, Dr. Kantarjan, one of my heroes who developed this drug with Dr. Drucker in Portland, Oregon. These two investigators were the ones who basically brought the drug back from a shelf at Novartis. Novartis had the drug on a shelf. They saw it, they brought it down, they started the studies, and they developed Gleevec, and Gleevec had, in the initial study, the initial study, 90% response rate with survival beyond 10 years. So now there are other drugs, other targeted therapies, because they bind the BCR-ABL. They basically downregulate the BCR-ABL, which is translocated in CML. So they basically eliminate the expression of that translocation, and patients go into remission. The initial drug was Gleevec. We still use Gleevec as the standard of care unless the patient has manifestations that show that the patient may not be at low risk. And there are tables that we have, the so-called table, and there are other tables that we calculate the risk. But most patients are low risk, and most patients are treated with Gleevec. Now, but there are other doctors, that's the first generation targeted agent. But there are some other doctors that many doctors believe, and there is some evidence in the literature that second generation and third generation drugs are stronger, get you to remission quicker, and have a deeper molecular remission. Well, you know, sometimes that's the truth, but they may have more side effects. There are drugs that you cannot use in diabetic patients. There are drugs that you cannot use in patients with chronic lung disease. There are drugs that you cannot use in patients with ulcers in the stomach, or as I said before, diabetes. So there are drugs that have to be taken on an empty stomach, or 2 hours after, or 2 hours after, 2 hours before, or 2 hours after dinner. So many patients we have to discuss with patients what drug is the best drug for them. I still use imatinib a lot, but I like dasatinib, which is Pricel, second generation, excellent drug, very well tolerated, but they all have side effects. So bosutinib could have diarrhea, ponatinib could have heart trouble, imatinib could have elevation of liver enzymes, rash, swelling, or stomach upset. So, I mean, you have to watch patients for side effects, and you have to decide what is the best drug for each particular patient. And I think I'm going to stop there because I want to answer questions.
Yes, thank you so much, Dr. Franco.
Yes.
We have about 5 minutes left, so we have a lot of questions in the chat box. I'll go ahead and start with one. One person wanted to know about fatigue, anything they can do about feeling tired, did not mention their specific diagnosis.
Well, fatigue, it's interesting because it could be CLL. I remember one patient that told me one day, doctor, I feel so well with treatment that I had no idea how bad I was feeling before. He said, I feel so good with the treatment, I'm now in remission, that I didn't know that I was so tired before. So many patients could have a lot of fatigue, and it may require treatment. On the other hand, it may be related to the anemia. So we may have to treat the anemia to make the patient feel better. Also, 3 things that I tell my patients, and I'm going to tell you. Number 1, drink a lot of water. Water fights fatigue. Hydrate yourself well. Water fights fatigue. Number 2, don't sit on the couch and watch TV. Walk, walk, walk. Go to the park and walk. Move. Number 3, whenever you're very tired, eat a banana. If you watch tennis, you see the tennis players in the middle of a game, during the 3rd set, they are exhausted. They open the bag and eat a banana. That gives them a couple of hours of energy. So, you know, anyway, but again, your doctor will have to tell you what's causing your fatigue. Go ahead, next.
Thank you. And we had someone ask about bloating with CLL, if you could repeat what you said about that and abdomen problems.
I'm sorry, say that again, what is it?
Bloating with CLL.
Bloating with CLL is mostly big spleen. It's the big spleen that is causing pressure on the stomach or on the intestines. Now, some drugs could cause side effects, could cause gastrointestinal side effects. You know, bloating, dyspepsia, you know, diarrhea, constipation. So, you know, it could be related to medication, but if it is related to the CLL, it's usually a big spleen. Next.
All right. Would like to know if there's any studies regarding TKIs and interaction with the new COVID injection?
No.
No. Okay. One person said, I had my test done last November and I'm still having pain in my hip. Is there anything that can make that better?
What test? Or would have to be hip pain. I mean, CLL or CML usually do not affect the bones. In most cases, the hip pain is due to arthritis in the hip. There are other conditions that could cause bone pain, like myeloma. But CLL, unless there is bone involvement, that's extremely rare. If there is bone involvement with CLL, you may need radiation to that bone. But the first thing you need to clarify with the doctor is whether there is bone involvement with CLL or whether it's arthritis or some other condition that is not related. It could be related to the bone marrow biopsy.
Yes, I think that's what he was talking about.
But that's extremely rare, extremely rare. I did 2,000 bone marrow biopsies before I quit, and my nurses do it, and the IR suite at Northside does it. I remember a couple of patients telling me about pain, extremely rare. Yeah, you may have to take some anti-inflammatory medicines, but anyway, go ahead.
All right.
Next.
We did have a question about your recommendation for people thinking about getting the booster shot
Yes.
for COVID-19. What is your recommendation with that?
Yes, booster shot right now is only approved for patients that are immunosuppressed or immunocompromised. So you qualify. Blood cancers, hematologic cancers, myeloma, CLL, CML, they all qualify. But there are a couple of things. If you're on treatment, you may not be able to respond. Because if you're on Imbruvica, Venclexta, all the drugs for CLL, you may not be able to respond to the vaccine. If you're on Rituxan and Gazyva, you're definitely not going to respond to the vaccine because you don't have lymphocytes that will work to respond to the vaccine. So that's the thing that I discuss with my patients. Now, if you are not on treatment and you are not immunosuppressed, then you can, in terms of the production of immunoglobulins, if you're not on treatment, it's fine. You may be able to respond to the vaccine, unless you don't produce immunoglobulins or proteins to fight infection. In order to respond to the vaccine, you should be able to respond to the vaccine with production of antibodies. If you don't respond, then you're not going to benefit. You need to discuss that with your hematologist, but those are the concerns. Number one, if you're on treatment, that may not allow you to respond to the vaccine. Number two, if you don't produce immunoglobulins because you have malignant lymphocytes, may not be able to respond to the vaccine. But yes, you qualify. Anybody with CLL, CML, CML patients should be able to respond to the vaccine because they have myeloid problems, not lymphoid problems. What you need to respond to the vaccine is good lymphocytes. Okay, next.
All right, in CLL, is there a quantitative low platelet level that dictates treatment is needed before symptoms or bleeding?
Yes, we don't treat low platelets unless the patients bleed or the platelets drop under 30,000. Okay. That's with ITP. That's with antibody-mediated thrombocytopenia and CLL from antibodies, from destruction of platelets from antibodies, less than 30,000 or bleeding. Now, if the platelets are dropping because of overwhelming growth of CLL in the bone marrow, then any platelet level, if the patient needs treatment. The patient may need treatment because of fever or fatigue or 200,000 white cells or anemia. So that's different. With destruction from antibodies, less than 30,000 or bleeding.
All right, it is after 1, Dr. Franco. I want to be mindful of your time. I know you are in clinic today. We have a few more questions. Do you want to answer one more?
Yeah, go ahead.
What is the meaning of enlarged red blood cells?
Yes, that's called macrocytic red blood cells, where the red cells are big. We measure them with a technique that is called MCV, medium corpuscular volume, and it has to be between 80 and 96, 98. If you're over 100, you're macrocytic, your red cells are big. Usually that's a production problem because there is a problem with the stem cells in the bone marrow, or B12 deficiency, or hypothyroidism, or hemolysis in CLL. if there is destruction of blood cells, red blood cells from antibodies in CLL, then the bone marrow is going to release reticulocytes or bigger red cells. So that's why the MCV goes up and you have a red cells that are bigger.
All right. Thank you, Dr. Franco. Again, I want to be mindful of your time. Just to let everybody know, thank you for attending today. I am going to be putting our evaluation link in the chat box. If you could please take time to fill out the evaluation. Those results help us continue to do programs like that. So it's very important that we get those evaluations back.
Thank you all.
Yes, absolutely. Thank you so much, Dr. Franco, for doing this for us today. And we hope to see you all soon in our next programs.
Thank you.
Thank you for joining Cancer Support Community Atlanta for this program. If you're interested in other live or recorded programs, please visit the online program tab of our website, cscatlanta.org, or follow us on Facebook. We'll be sharing additional information on upcoming programs.